Okay. If you mute this. Okay. Great, thanks very much. So I'll start with a bit of an introduction. Today we're really happy to be here to share the recently released eReport for the hip fracture quality standard. Today we'll be describing Ontario Health's hip fracture quality standard and how the quality statements relate to key hospital performance indicators, and how to access and navigate a hip fracture quality standard eReport, and to explore recent performance on key hospital indicators. So just before we get started, I'm going to give a quick overview of the hip fracture quality standard for those of you who might not be familiar with the quality standards. Quality standards are a smaller set of high-impact statements that describe optimal care where identified quality gaps exist in Ontario. So they're developed to inform clinicians, patients, and care partners what quality care looks like. They're grounded in the best available evidence, and they focus on conditions or processes of care where there are large variations in how care is delivered, or where there are gaps between the care provided in Ontario and the care patients should be receiving. The QR code is a link to the hip fracture quality standard. Now, the quality statement topics, we use clinical practice guidelines to develop the quality standards. We don't always cover the breadth and depth that a clinical practice guideline covers. We develop them with an advisory committee, and they prioritize key areas for improvement in Ontario. So when this quality standard was developed, there were 15 quality statements that were prioritized as key areas for improvement. And you can see that they cover the whole patient journey from admission. There's a few surgical quality statements, and then through to rehabilitation and secondary prevention. So the hip fracture quality standard was updated in 2024 to capture new or updated evidence published since its original release in 2017. Significant quality gaps still exist. 1 in 4 people wait longer than the recommended 48 hours for surgery, and there's wide variation across the province and regions. 1 in 3 people remain in hospital, but are designated as requiring alternate level of care after surgery for hip fracture, with a median ALC of 5 days. And mortality with 1 year after hip fracture was 20%. Mortality within 30 days ranged from 2 to 12% across hospitals. So consequently, Ontario Health has identified hip fracture as a core area for quality improvement, and we're currently developing a multi-year approach to spread proven change ideas. And here we've highlighted the great work that's been done at London Health Sciences Centre in a spotlight report, which has been published and is on our website. The next slide includes the implementation tools and resources. So after we develop the quality standard, we also produce a patient guide targeted for patients and caregivers, a placemat targeted for clinicians. We have measurement documents, technical specifications for measurement, how to measure improvement for overall success of implementation of the standard. We have a case for improvement deck. And then more recently, we've released the hip fracture eReport that we'll be highlighting today. And our next step will be bringing together an advisory group to develop an implementation toolkit. And that work is currently just getting started. So I'll pass it over to Jerry, who is going to give an overview of the hip fracture eReport.
Thanks, Carol. Can I share my screen? Let me just try this. Andrew. So what's everyone seeing right now?
Hey Jerry, we can just see the overview slide, like the eReport overview slide.
Right, yeah, so this is not,
Sorry, I also want to apologize. I think we may have had the wrong slides up. So the slides that Carol were talking about, I'm going to post them afterwards so everybody has access to those as well. So I had the eReport slides up.
I'm wondering if everyone can see this.
Yep.
Okay. Technical difficulties here. Okay, so actually I will hand it off to my colleague, Catherine, um, who will be able to provide a brief description of the quality standard for hip fracture and the eReport, and then I will do the demo for the eReport. So
Thanks, Jerry. Do you mind going back to the slide deck?
uh, the slide deck. What can we see right now?
Okay.
Like
Next
this.
slide, please. Yeah, next slide, please. Okay, great. Thanks so much. Okay, so before Jerry gives the demo, I'm just going to give a bit of a general information on the background about this eReport. So this was launched on April 28th as part of Ontario Health's ongoing efforts to improve care for hip fracture. And as Carol has mentioned, it's based on the quality standard, and the data that is displayed on the dashboard includes people who are ages 50 plus who had surgery for a fragility hip fracture in an Ontario hospital. So this is an interactive dashboard that Jerry will walk you through later, and it allows Ontario hospitals to view their hip fracture surgery hospitalization data. And the data sources come from health admin databases below. So there's the discharge abstract database, which includes data on inpatient hospitalizations, which is where we draw most of the reports data from. We also have indicators that use the National Ambulatory Care Reporting System, which has outpatient data. And we also use the Continuing Care Reporting System, which has data on facility-based continuing care services. And the dashboard will be updated quarterly, so April, July, October, January. And this is available to users via the eReport portal, which I will talk about after Jerry's demo. Next slide, please. Okay, so before we dive in, these are the indicators and measures that are in the eReport. So the first two are mortality rates and admission rates within 30 and 90 days. The third one is the percentage of previously community dwelling people who undergo hip fracture surgery and then are later admitted into long-term care within 90 days. Number 4A and 4B are about wait time to surgery. So one of the statements in the standard is that people should receive their surgery within 48 hours of arrival. We also the indicator is about the percentage of people who have that accomplished. We also included a percentage within 24 hours of arrival at the hospital as another measure to look at. 4B is the median wait time to surgery from their arrival at the hospital. Number 5 is the percentage of people who had a stay in an ALC, as well as their length of ALC stay. And we also have some additional information. Number 6 is percentage that are admitted from community versus another institution, for example. Number 7 is the discharge dispositions of their hospital stays. Where do they go afterwards, or where are they discharged to? And then number 8 is delirium among hip fracture patients. So these indicators and measures all align in various ways with the hip fracture quality standard and other initiatives at Ontario Health. And if we can dive into the demo, I will let Jerry take it from here.
Sounds good. Thanks, Catherine. So sorry about all the technical difficulties, but we will continue with the demo now. So now that everyone can see, this is essentially our hip fracture quality standard demo version of the eReport. The first page is the summary of hip fracture in Ontario. We have in the middle here, or on the left side here, the volume of hip fracture hospitalizations in Ontario for the fiscal year, the most recent full fiscal year, which is 23-24. And at the bottom, we have rate of 30 and 90-day mortality, as well as the volumes over a period of 8 years back to 2016 and today. In the middle, we have a list of the top 10 most greatest volume of hip fracture in Ontario. Again, the names and the data are dummy data, so it's covered for privacy reasons. It's covered, but in the real hip fracture eReport, it'll state the names of all the sites for volume in the left side, the 90-day mortality in the middle, and longest median wait times, the top 10 sites as well in Ontario. At the bottom here, we have ALC, some stats about percentage of hip fracture with any time spent in ALC, median number of days spent in ALC, and the 90th percentile number of days spent in ALC. So this is the summary first page of the eReport. Just wanted to take everyone through what these dashboards are generally like. So at the bottom here, we have all the different tabs for each of the different indicators, and we'll get into them. But in order to navigate the eReport, I think Catherine will also talk about how to get access to the whole system with a one ID and all of the eReport access privacy hoops that you have to get through. So moving on, we will talk about the discharge outcomes by regions. So we can talk about, firstly, overall in Ontario, we have 6 different OH regions, and each of the regions are listed here. We omitted 2 of the regions, Northwest and Northeast, for the purposes of this demo because there are very few sites in each region. But in the real eReport, there will be 6 regions. So what you can do is you can select each of the different regions, and the eReport will reflect the indicators for those regions specifically. So you can look at by fiscal year as well as by fiscal quarter. And this is just a comparison for the different OH regions, right? So you have Central Region and East. And if you want to look deeper into 30-day mortality, you can hit the focus mode on the top right corner. And you can see a more full screen view of the data. So on the bottom left here, we have percentage of previous community dwelling people who are admitted to long-term care within 90 days. So these are individuals who came in through the community to the emergency department, and then they left their admission to a long-term care home. And at the bottom, we have discharge disposition after hip fracture hospitalization. So here we can do by fiscal quarter as well as fiscal year. And again, you can select different OH regions. So this is the discharge outcomes by regions tab. Moving on, we have admissions by region. So what happens during an admission? again, we can do fiscal quarter and fiscal year, but in this situation, we have at the top percentage of ALC, median length of stay in ALC, and the top 90 percentile of ALC for each region. And in the middle, we have percentage of hip fracture hospitalizations from people dwelling in the community. And so you can see a majority of individuals who get admitted for hip fractures come through the community. And we have some wait time information at the bottom here. So if we're focusing in on the East region, we can see that there are non-ED entries and ED entries. So the non-ED entries, just to give a brief explanation of this, is it's really a relic or a limitation of admin health data. Some hip fracture hospitalizations do not have an associated ED entry. And so there will be two separate cohorts essentially. And so the ED entry reflects a more accurate look at the patient's journey because there is an associated ED entry. They enter through the ED and then they get admitted to the hospital. So the blue is really what you want to focus on. And you can see we can compare that between Central, East, Toronto, and West regions as well. So these are the regional level of the indicator. Next, we can dive into the site levels for all the sites that deal with hip fractures in Ontario. So this page, discharge outcomes by site, is really a reflection of that first slide that we showed, the first tab that we showed. We can specify which fiscal years that we're looking for. So we can look into, for example, 2020 to 2024. And then we can click each individual site. So I want to focus in on two mask sites here. There is one that is called Daft, and there is one that is called Jor. So these two sites are very similar in size and very similar in how many hip fracture patients they deal with each year, but they have differing results in the indicators, as we can see. So you can look at their 30-day mortality, their 90-day mortality, as well as their 30 and 90-day readmission rates, and the discharge dispositions as well. Focusing on these two sites, we can look at what happens in the admission. So again, we can choose a fiscal year, and we can also find which sites that we're interested in here. So the power of the eReports is that it'll automatically update, and you can see the differences in specifically here, percentage of people who undergo hip fracture surgery within 48 hours of arrival. It's a much higher percentage in this site called Daft compared to Jor here. And we can focus in more on that in the next tab as well. So actually, I will talk about wait times to surgeries first. So this is essentially an even more deeper focus on wait times. So from 2016 to 2024, we have selected the two sites, and we can look at, for the ED entry patients, what are their median wait times? And you can really see a difference after COVID, the pandemic, that there is a massive change in their wait times between Jor and Daft. And as we mentioned, they're both from the Eastern region, and they're both similarly sized hospitals. And so this eReport can really highlight these differences and can really emphasize and allow different sites to understand where they stand between their peers and what more they can do. It can help get those conversations started. So this is the wait times to surgery. As well, we can look at mortality and readmission. So this is the list of all the sites listed in descending order by 30-day readmission. We can look at 30-day mortality, for example. And we can focus in on, if we're looking at East region, the two sites that we're looking at. So again, as we saw, Jor had much higher wait times, mortality as well. It has 9.2% compared to about 6.3%. So there is a difference here. Specifically, if we look at the full 2023-24 year, again, 8% to 6.5%. So there is a clear comparison between all the sites, and it really facilitates that. So lastly, we can talk about some delirium. So delirium is also tracked as one of the indicators, and we can look at the different sites. So for the two sites that we're focused in on, Daft and Jor, you can also see a stark difference, but this time it's in the other direction here. Let me get rid of this. So the delirium rates, or the reported delirium rates, are much higher for DAF 93 than Jor. And that's a lot of people have found out that it's because the hospitals are measuring and noting down the delirium rates in their patients a lot more. So not necessarily that the delirium rates are higher, it's that they're measuring it more often in DAFT compared to Jor. So this is just a little bit of a demo on what can be done with this eReport. Again, this is all dummy data, but we can look at if we wanted to export or take this data out into Excel format. This is the data table with all of the indicators listed. We can select the specific region that we're interested in here, and the specific fiscal year that we're interested in, and we can just export on this table itself. So it should be right here, more options, export this data, and you can get all the data in Excel format, in summarized data format as well, right off of this page here to do further analysis and other things. So this is another powerful thing we can do with this eReport, specifically measuring all the hip fracture and the indicators for that. So that concludes the demo. I know it was a little bit rushed, but is there any questions, or we can move on to talking about how to access and.
Jerry, I'm just going to give an opportunity for some questions because there's a lot of data that you went through there, and I think it's
for sure.
really incredible data. Thank you for also answering the questions in the chat as we go along. Does anybody have any questions that they wanted to highlight? Okay, so if there's nothing at the moment, then you want to move on to Catherine?
Yeah, for sure.
Catherine, do you want me to share the screen again?
Sure, yeah, it's easy for you. Thank you.
I do see one question in the chat there now, Jenny.
Oh, okay. Are you able to?
Yeah, I can answer that. So the time lag is about 3 months. So we receive the data from Kai. So for example, in June, the data reflects everything that was from March and prior to that. And then we try to update it as soon as possible. Okay, great. So yeah, thank you so much for sharing, Jenny. So to access this eReport, it is behind a portal, which you will need a OneID for. And the access is among anybody who can get a OneID account. So people who are supporting quality improvement or implementation initiatives, including partner organizations. So it's not just hospitals that have access. So you need to email a local registration authority, and the email is on the screen there, or your hospital local registration authority to request the OneID account. And then you'll need to register using some pieces of ID. And then you will be provisioned this OneID, and you will need to ask that your OneID account is associated with the QS eReports QS reports section of the eReports portal, because the eReports portal includes other reports that Ontario Health produces that are not tied to this. So you will need to specifically ask for access to quality standards reports. And then you will log into the eReport page using your OneID credentials and select from a drop-down menu where it says, the tab says quality standards, and then you just select the relevant eReport that you want to see. And you will be able to see all of the quality standards eReports. For example, we already have one for sickle cell disease, and we have one for hip fracture right now. Any further questions, please reach out to quality standards at ontariohealth.ca. I'm seeing one question in the chat about data for rural areas. That's a really good question. So in terms of the patient journey where they present and then they get transferred, that's where there's a data gap that Jerry mentioned before, because it's sort of hard to link them back precisely to the ED that they visited. So that is the next step that we're investigating for those patients. I think right now the split is something like 85% go through the ED of the hospital that they get the surgery at, but there's the remaining 15% that show up at a different hospital maybe, and then they get transferred into the surgery hospital, or they're admitted through some other unit.
Thanks for answering that question. I was just asking because in rural areas, like the patient journey is often different. So if we're measuring, say, time to surgery, well, if they're waiting 3 days in their local rural hospital, but then when they get transferred to the surgical site, they only wait 12 hours or something, right? And same too, when they get transferred immediately post-operative, it makes it look like there's like 0 ALC from that site, let's just say, right? When actually they might be waiting ALC just in the other site. So it's just when you're thinking about systems in rural areas, right? You have to kind of know the limitations of the data.
Mm-hmm. That's a really good point. Thank you for your insight. Yeah, the ALC that we currently measure right now are only from the discharge abstract. And so there is that limitation there. If they were in ALC before they got the surgery, then that's a limitation that we are not able to capture right now with the data, but we are definitely going to investigate.
Yeah, and Alex, that is something that has been brought up before when we were having these initial discussions. And Frank, he's an emerge physician who often goes to the rural areas, so he has a much better understanding, having worked rural and LHSC kind of simultaneously as well in a rural and urban hub. But thank you for bringing up the very unique needs of our rural population and how we collect the data. Gabrielle has a question as well. Gabrielle, do you want me to read it out, or do you want to just ask the question?
Sure, I can just ask. Thank you very much. I'm really excited to be able to see this data and be able to get our hands on it. But I was just noticing that under discharge disposition categories, it does have a category for transfer to another facility for inpatient care, but it doesn't seem to break it down further into who's actually going to inpatient rehab, which is part of the hip fracture standard. So I'm just wondering if there's a way to be able to understand who's actually getting rehab. And I guess that goes for community as well. When people are discharged in the community, who's actually getting rehab?
I think currently right now the way that the discharge disposition categories are set up according to the discharge abstract database, I don't think you can like directly break it down like that. We would have to do some linkages to investigate this further. But yeah, there is a big chunk, about maybe 9 or 10%, who are transferred to continuing care or residential care that could be in there. Or yeah, they could be part of the transfer to another facility. So we can definitely investigate that further.
Thank
It
you.
does require linkage to another database. Yeah. Thanks for the comment. Yes, age criteria is 50 plus to align with the quality standard. I think this was in consultation with our quality standard advisory committee, as well as being developed with other guidelines out there that align with age 50 plus. I think it's just to capture as much of the population as possible. Although yes, a lot of these patients are older, so a lot of them are age 65 plus. There is a methodology tab at the very end that users can review. Do we need to? Oh, okay, I see. Yeah, I think we should refer you to the quality standard page. There is a technical specifications document that you can find on the page. But the technical specifications for that page mostly aligns with the eReport. There are a few nuances as we were developing, but that's a resource that you can go to for now. I will ask one of my team members to drop a link into the chat if that is possible. Yes, thank you. Okay, yeah, thanks, Angela, for that point. We will definitely investigate the discharge disposition further.
Catherine, there's just a comment here from Marcia as
Yes.
well about criteria for surgery to rehab within 6 days. Is that something that could be looked in through the eReport if that's the as well?
Yeah. Yeah, that's definitely something we can look into to add more information on. Yeah, it seems like there's a lot of good comments about rehab and their interest in where they go afterwards. It's definitely something we can.
It's Marsha. I just with the report that gets sent out to hospitals from GTA Rehab Network around hip fracture metrics. One of them is ED admission to surgery, and then the other is around surgery to rehab. And then that is included in the updated 2024 quality standards. So if that could be incorporated into this eReport as well, I think that would be super helpful.
Great, thank you. We'll definitely add that to our list of refinements and updates.
I was just going to say to Megan Kelly as well. I played around with this. I requested access to the eReport just by emailing all of the ones that Catherine has shared, and I got access within 24 hours. It was a pretty easy process. And then once you got access, all the technical reports are there, and it's quite fun to play around and see how you compare kind of against provincially and also within your region as well. Any other questions for the quality standards team? Okay, well, thank you so much for sharing this with us, bringing this to attention. I think one of the things that we're going to be looking at our site, and I'd love to hear what everybody else is going to do, is now that the eReport is available, what are we going to do about it within our site, and how are we going to be able to use this to implement quality improvement going forward? And I think with the work that Ontario Health is going to be doing around developing a toolkit, I think that's going to be a really helpful resource for centers as they move forward with this as well. So thank you very much. Thank you for that great presentation. Okay, so we're going to now move on to the case presentation section.